All right, this is an overlapping question for you guys before we invite all of the panelists back. So, if a patient has stage 4 disease, they're on a drug therapy, and then they meet Dr. Antonov, they are the right patient with the right time, with the right team, and you're going to take them to the operating room. One of the things that you both have to balance and talk about from a multidisciplinary standpoint is to hold their drug treatment, right? Before surgery, after surgery. What are the pros and cons to that? How scary is that?
I'm happy to address that. So I think this also plays into really understanding which patients are at the right time for it, right? And so I always try to explain to patients that in general, we want to have control of the biology. We want to be beating the biology at the time that we operate, with few exceptions. And the exceptions are patients who are progressing on a drug therapy, and we have an operation that can get rid of 100% of their disease.
Hmm.
We don't always have to be able to operate on 100% of the disease, but if we aren't going to operate on 100%, we need to be operating at a time when we are beating biology. And the reason for that is that even if we didn't have to stop drug therapy that's helpful in any setting, anytime we do any operation on anybody, we are causing trauma. And in my mind, I like to think about that as a bit of an insult to the immune system. We don't think about that, but a patient who, whether they have appendicitis or they've gotten in a car accident or any type of operation that we do, there are cells that need repair. There's tissue that needs repair. There's immune function that goes into healing from an operation. And so when we have someone who maybe is on their third line of therapy and they're progressing and they have a lot of disease sites outside of what can be operated on, that's not the person who should have surgery, because surgery is going to cause more harm than good. Most of the patients of stage 4 and are going to have surgery, we think about timing at a time when either the response to the drug has plateaued or it is peaked or whatever it may be. It's not terrifying to stop the drug. Some patients are more scared of it than I am. And the amount of time that we have to stop it is a lot of it is kind of based off guesses. We have medical oncologists who will tell us this drug is probably out of the system after 2 or 3 days. It's probably okay to stop this targeted therapy 2 or 3 days beforehand. We often in our practice stop a lot of our targeted therapies 7 days beforehand, because that's what we did on our clinical trials and we have experience with that. We also kind of, without, anecdote, just based on anecdotal experience, we put the drug people back on these types of oral drugs the day after the chest tube is removed, based on hypotheses that we think it prevents, infections from the surgical site. But those are targeted therapies, which are going to be different than things like chemotherapy and immunotherapy. And, I feel pretty strongly that patients should be off of chemotherapy or immunotherapy for a minimum of 3 weeks before surgery, ideally 4 to 6. It depends. Like if it's maintenance pemetrexed or something, 3 weeks beforehand is probably okay. But people who are getting, cytotoxic platinum-based chemotherapy, we want it to be 4 to 6 weeks. Immunotherapy that we know can cause pneumonitis, which then compounds with risk of surgery. We want at least 3 weeks before surgery. And then the biggest concern is after surgery, when people don't realize that they're still healing. Their body's immune function is still, it might look good on the outside, but there's a lot of stuff going on the inside. And restarting an oral targeted therapy agent is one thing, but jumping back to chemotherapy or immunotherapy can be really dangerous. And sometimes people get those types of drugs locally and then they go somewhere else for an operation. And we have to ensure that communication is appropriate and that whoever did the operation is involved in any discussion about restarting any type of therapy after surgery as well. I know it was a really long, drawn out answer, but I think it's super important points for patients to hear.
Yeah, thanks, Dr. Antonov. Dr. Patel?
Yeah, I would agree and echo all of that. I think that it's really important that the medical oncologist and the surgeon are having a communication and talking about exactly what to do. I think I agree with everything she said, from starting the TKIs and stopping those, as well as the cytotoxic chemotherapy and immunotherapy. And I always try to reiterate to patients that, even though you're not getting your immunotherapy, if you were on that, we do know that there is effectiveness of the immunotherapy past that 3 week mark. And, we see effects of the immunotherapy up until 3 months later. And so just because we haven't received our dose, it's not that, we're not still doing something to the cancer. And when it comes to the cytotoxic chemos, we do want the body to have recovered from the last cycle of chemotherapy from a count standpoint, so that we are going into the surgery, at our best, so we're able to tolerate it the best we can.